And now it's my great pleasure to announce our next speaker, Dr. Chandra Nadai. He's going to talk about the role of endovascular therapy in the treatment of MEVO, lessons learned from the latest randomized controlled trials.
Thank you very much for the kind invitation and for the opportunity. I'm in a very lucky position because you already had two very nice presentations, one on the technique of distal thrombectomies and one on time windows, so I can base my talk on them. Here I don't have to highlight how important it is to get appropriate treatment for stroke. It's the major cause of death and disability, and of course our region is heavily influenced by this disease. We all know this. This is the classic first golden hour, let's say, trials. So the meta-analysis of the first 5 HAPPY trials demonstrating that basically mechanical thrombectomy doubled the patient who would be self-sufficient. And that's why basically the indication was the indication that these trials were quite narrow, but then based on this very, very high treatment effect, it could be expanded. Currently, we have evidence for the major vessels inside the brain. So basically, the large vessels, that would be the terminal carotid, the first segment of the MCA, and maybe the dominant M2s, the basilar artery, and the P1s. But anything beyond, we don't really have evidence, and that's what the trials were aiming for. We do know that we are facing a very, very effective treatment in large vessel occlusions, but the question is whether we are going distal from this lesion, do we still maintain this large therapeutic effect or not? This figure is about the expanding indications of thrombectomy. It is actually showing the volume of DVI lesions of patients being admitted for acute stroke within 24 hours. And this is why we don't really speak about time windows anymore, because basically collateral circulation is much more determining the lesion than time itself. So all these patients represented with the different dots had a M1 occlusion, but you can say that in some ones with poor collaterals, even within the first 4 hours, you had already a huge lesion that could hardly be treated, while others could be treated even to 24 hours because of their collateral circulation preserving and only having a very small definite lesion. So in the last 10 years, our indications actually grew from the original 6-hour to the 24-hour, and now with the large core trials, we found evidence that we can even treat the large volume lesions. So basically, everything was positive from 2015 on, and we tried to find basically the barrier, the final barrier where we should not bypass the borders of our indication. And yeah, I think we have found at least one. The next frontier, of course, is the MEVO. So what if we go beyond the traditional indication? Will we still be effective? Of course, we are not treating images. So basically, the indication for going to distal vessels would be, for sure, debilitating stroke. So you need to have symptoms that are very important. If you're treating someone with mild symptoms, then your health benefit will be much less, and your complications may be much more. How many cases do we talk about? This is a very interesting study from France, Dijon Registry, which basically analyzed stroke patients, 284 stroke patients, and they scanned all of them, and they were looking for the distribution of various sites of occlusion. And we can say that basically 34% of all visible occlusions qualified into this distal MEVO category. So we are actually talking about a quite subsequent patient population. So we do have evidence for the proximal segments, but as you can see, once you're trying to go to the 4th and 5th, then you actually are bypassing quite a few turns, and it's becoming more and more risky. The diameter of the vessel is small, and you're actually stretching the vessels, causing potential injury. So that was the rationale that they actually had to do a randomized trial to prove that the treatment effect would be maintained in these regions as well. These are the various studies that were started with a little different indication for the inclusion, but the overlap was substantial. So basically, a non-dominant MCA, M2s, M3s, M4s, A2s, and P2s were usually included in all trials. How do you find the MEVO? That was also a very important thing that has to be found. Distal occlusions are not so easy to depict, and if you're only looking at original images, CTA images, basically many of them can be missed, and that's why perfusion really is helping to find MEVOs. Perfusion imaging depicts the occlusion, and then you can identify it, so your sensitivity increases substantially by using perfusion imaging. How do they do by medical therapy alone? That's also a very important question, because that would be the alternative. Well, excellent functional outcome is only achieved in 50% of the cases. So there is quite a bit of room for improvement from that. And what is very important, that early recanalization was strongly associated with the good outcome. But this early recanalization doesn't occur in half of the patients only treated with thrombolysis. So it would be reasonable to speed this up and to try to help these patients. That was an interesting study, basically laying the foundations for the ESCAPE MEVO. They asked interventionalists all over the world how they would be motivated to treat EVT. And we can say that about 40% would offer it before the clinical trials to the patients who receive thrombolysis, and almost 80% of the interventionists would even offer it if the patient could not receive thrombolysis. So basically our profession was supporting the treatment of MEVOs. There were some studies demonstrating effectiveness, like this meta-analysis is a very important one, but we still should highlight that even in this meta-analysis, a substantial number of bleeding complications could already be depicted, corresponding to this difficulty of the navigation of catheters and the procedure itself. And another important thing is that you had a mortality up to 20% in this patient population. In the former study that I just showed you with the thrombolysis, the mortality was only 8.9%. So that's a warning sign, and that's another very important reason to really prove that we are not doing harm with the clinical trials. Okay, these are the endpoints of the various studies, and I will mainly talk about the ESCAPE MEVO, because that's the trial that we were involved in, and that's what we know the most about. This is a patient who was actually randomized in the ESCAPE MEVO population. If you look at these images, it would be not even easy to identify the occlusion site, but then we did the perfusion using the brainomic system that István already talked about, and that really well highlights the site of the occlusion. And based on this, we could actually identify on the 3D, and we were able then to identify it on angio and do a successful perfusion. The last patient in the ESCAPE MEVO trial was actually randomized in Budapest, and they were very happy, the trial team with us. They sent this GIF to recognize our efforts. And the results were presented at the ISC in 2025, so just a couple of weeks ago. We were quite disappointed with the result, but I would refuse any allegations. We had nothing to do with the events occurring around the Congress in Los Angeles, so it had nothing to do with us. Anyways, two papers came out at the same time with the Congress presentations. One was the ESCAPE MEVO, which mainly included North American, Canadian, German, English, and Hungarian centers. And at the same time, they have also published the DISTAL, which was a Europe-based study. It was run from Switzerland, and it was actually run mainly in European sites. There was some little differences between the two trials. They were absolutely running parallel, and they had similar design, but the ESCAPE MEVO allowed inclusion of patients within 12 hours of symptom onset, while theoretically DISTA would have allowed it until 24 hours of symptom onset. And also, ESCAPE MEVO was based on stent retriever, so the first attempt had to be made by a stent retrieval, while in the DISTAL, other techniques could be used, aspiration as well. When we look at the baseline characteristics of the patients, you can see that the interval between time last seen well and randomization was 4 hours, even in the DISTAL trial, so it didn't matter that it was allowed to go all the way to 24 hours. Most of the patients would be recruited in the early time window anyways. And these are the results. Unfortunately, there was no significant difference in the distribution of modified Rankin scales. So basically, the thrombectomy itself did not improve the outcome. Why is this? Well, probably the most important problem is that if you're going into a distal vessel, then your core to hypoperfused penumbra ratio will be much smaller. And the problem is that probably that's why you don't have such a large treatment effect as we have proven with the proximal occlusions. There were, of course, other issues with the trials. Serious adverse events were higher in the EVT group in ESCAPE MEVO. There were more pneumonias, recurrent strokes, and worsening of index strokes. Importantly, perforations were not that frequent, so we only had 5 perforations in the whole study. Symptomatic intracranial hemorrhage, however, occurred in a larger proportion of patients than in the control arm. And another problem is that about a quarter of the patients had incomplete reperfusion. So many patients did not get properly reperfused, and the workflow times were also slower than in the large vessel occlusion trials. So that might have been another one. And also, general anesthesia was encouraged. It was used in 9% of the original large vessel occlusion trials, but it was used in 40% of the MEVO trials. And maybe that has also contributed to the longer time flow and to the longer workflow times compared to the others. When we look at subgroups, well, we can say that probably the only signal that would signal positivity was in the patients with more severe symptoms. They could benefit more, but altogether the results are negative for all subgroups. It's important to know as a limitation that, as you have seen from the attitude of operators, we know that operators really believed in thrombectomy for MEVOs. And there might be a problem, both trials acknowledge it, that maybe the patients who really had bad symptoms were treated by thrombectomy outside the trial. So some operators may have been reluctant to randomize cases if they were really having bad symptoms. We had this issue in Budapest as well. I had to really press on my team to randomize, because that's how you can get the evidence. So to sum it up, of course, we need to do CTA in all patients with stroke in order to identify large vessel occlusions. When we don't really see the large vessel occlusion, but there are debilitating symptoms, CTP should be performed to identify potential distal ones. Thrombectomy for MEVO can be considered if IV is contraindicated and if the symptoms are severe, but the routine use of EVT in MEVO is not justified anymore. And we need to do everything to reduce the time spent in order to have the most treatment effect. Thank you very much for your attention.
Just a quick question there. It's lovely to see that, a fantastic presentation, first of all. Lovely to see that there's a switch from the timings being so important to now collaterals. I'm just thinking for kind of preoperative cases, do you see blood pressure control being important in this as well, especially when transferring patients from diagnostic sites to interventional sites?
Yeah, I mean, the most important thing is not to lower blood pressure too much until the patients have actually undergone successful reperfusion. The issue with blood pressure lowering is that it's difficult to adjust it properly. So, for example, for thrombolysis, you have to be under 180 millimeters mercury to initiate. And we often see that when they try to get under 180, they end up with 110. And then actually it is worsening the stroke considerably. But collateral circulation I think is more determined by the genetics than by blood pressure itself. We have actually done an analysis in a subgroup of our patients. Back in time, we did repeat CTAs and in all patients. So we do have a comparison study with initial CTAs and repeat CTAs, and there are some patients who are improving their collateral status. They will have a much better outcome, but surprisingly, this is not really linked to blood pressure. We have tested it. So you can just ruin blood pressure issue. Raising blood pressure for anyone would probably not help collateral circulation and help the outcomes.
Thank you.
Thank you.
Thank you. Great presentation. I enjoyed it. Just one quick question. So you mentioned general anesthesia might be a problem. For the MEVO patients, did you try to perform MEVO without general anesthesia?
Yeah, I mean,
and what do you mean by
We didn't use routine general anesthesia in our MEVO patients. Those ones who were not cooperating, in them, of course, but in many of them we could actually perform conscious sedation. It was 40% of the cases in the whole trial that actually went under general anesthesia, so 60% was still under conscious sedation. But this 40% is basically a large number, and it may have contributed to the longer workflow times. If you look, the problem is that if you would be doing general anesthesia in a strict protocol and everybody would be ready and it would be always the standard, then probably it would not cause a problem. We know it from the Siesta study from Heidelberg. They have actually demonstrated that if you have a very stringent anesthesia protocol being there and keeping it and being very routinous in it, then you will be able to get just as good results. But the problem is that if you call anesthesia from time to time and they are not used to coming, then probably it will prolong your workflows compared to the standard.
Thank you. And another question added to this one. So if you divide these two groups of patients, 40% with general anesthesia and the rest in conscious sedation, what was the percentage of intracranial hemorrhage or subarachnoid?
Yeah, I don't know this yet, so it is not published currently, this division, but they might come out with the paper on it later on. But currently, I cannot tell you about this specific comparison.
Thank you.
And I'm wondering, also thinking back about the first trial showing that thrombectomy does not work, where we had inclusion of devices which were not really suitable for thrombectomy. Do we think that we're at the beginning of the development of new devices, and that probably the choice of the stent reverse may have, or that we're not quite there yet? I think we need to be quite careful because these results always stay for a long time. Yeah, it's a randomized study, and the development in our field is so fast. And what we can do now, 20 years ago, we would have thought was impossible. So I think
absolutely.
we need to see that.
I mean, we had the
first results.
Both in the big trials, both in the ESCAPE MEVO and in the distal, we had about a 70% reperfusion rate, complete reperfusion rate, which is lower than the general LVO practice. So maybe if we are able to develop some device or some technique that would actually raise this to 90%, then the treatment effect may be more. And also because of you have this negative result, I mean, it will be much easier to substantially with a new device subsequently do a new randomized trial, because people would be not treating probably the patients outside the trial because of being afraid of not offering the therapy.
Talking about technique in the future, what do you think about the potential resurrection of intra-arterial thrombolysis for MEVO?
I mean, yeah, that is a very important point. I think we should actually use intra-arterial thrombolysis more and more. Maybe MEVO indication would be one good indication, and also when we have incomplete reperfusion, there is some small there are some small study data already showing benefit, and there are large-scale trials going on. But definitely, I think that might be one solution.
Perfect. Thank you very much.